this is the highest unmet clinical need that we have. The best treatment of relapse is the prevention of relapse, because independently from the genetic abnormalities, with very few exceptions, resistant relapsed AML are doing very bad with the current treatment that we have available. In this light, I think that prevention of relapse through maintenance therapy, that is really a hot topic right now in the AML field, should be one of the major leader of how we should manage this kind of patients in the future. Right now, the suggestion that I have is to test the genetic of the disease. If the patient is IDH1 positive, then you should use Ivosidenib, IDH2 Enasidenib, FLT3 gilterinib or Quizartinib, and try to selectively target the mutation that is present at relapse. So to retest the patient, and if the patient has a genetic aberration, the best treatment should be the treatment targeted that genetic lesion. Otherwise, if it is a young patient, there are nice data with venetoclax plus hypomethylating agents used as a bridge to transplant in patients without genetically targetable lesions. If it's an elderly patient, it really depends on the age, on the prior treatment, and on life expectancy. We all know that even with the best treatment available, that is venetoclax plus hypomethylating agents, we have a median overall survival of 14.8 months. So the resistant relapse setting is a hurdle that is very difficult to jump.